Much, Nora. So our next speaker is Dr. Rohit Loomba, who's from UCSD, and he's going to be talking to us about fatty liver.
Thank you, Jeff, and the organizers for having me here. It's always a pleasure coming to this meeting. I remember when I was a fellow at UCSD, I would come here, spend the weekend. It's always wonderful. And the other special thing about our SoCal GI community is that it's very interactive. And many of the research advances that we've made are in collaboration with many of you in private practice. Because I would get a call from you, and there will be a really detailed discussion on some of the aspects of what we need to do as a community together to find answers for our patients, and that leads to some of the research questions that we've put forth. So all thanks to many of you. These are my disclosures, and this is going to be the outline of my talk. I'm going to briefly discuss some of the new things that are coming up, also present some data from EASL, and where things might be moving in terms of the phase 3, some data that was released as press release, and also the other phase 3 trials that are underway currently. So NAFLD, as you all know, is the leading cause of chronic liver disease in the United States. We think about 80 to 100 million Americans may have it. There's a clear ethnic predisposition. Asian Indians have one of the highest risk, and that's one of the reasons why I'm interested in it, followed by Hispanics, Caucasian, and African American protected. Risk factors include metabolic syndrome. The key genotype that we know is associated with fatty liver is PNPLA3. There are 3 other genotypes that are associated with it, and then there's recently recognized one protective genotype. So you could be protected because of one or your genetic makeup, and that's the HSD17B13. Now, how do we diagnose NAFLD? I think it's important to have that diagnosis firmly established as we discuss things further in the next 29 minutes. It's diagnosed either on biopsy or on imaging, with evidence of hepatic steatosis with 5% or more of hepatocytes infiltrated with fat in individuals who drink little or no alcohol and who have no other competing cause for hepatic steatosis, such as a medication, lipodystrophy, or hepatitis C. Every Monday morning, I have a NAFLD clinic, and I'm trying to sort out if my patient has the progressive form of fatty liver disease that's called NASH versus NAFL. And you can see the liver biopsy of these 2 patients seen in my clinics looks very similar. The only thing that differentiates the patient with progressive liver disease, shown by the arrow, is the balloon hepatocyte. So that particular patient's fate is progressive, and this patient is at high risk for dying from liver disease based upon that particular entity. So many of our diagnostic algorithms that we are trying to define is somehow to capture that or sequela of that, which would be fibrosis. Now, this is about 10 years ago. People used to say that if you have NASH, you have NASH, and those who are NAFL never progress. That's not true. People are fluctuating between these 2 states all the time. So a patient with NAFL, if they gain about 20, 30 pounds, they're moving towards NASH. And a patient with NASH who is losing 10, 15 pounds is moving towards NAFL. So this is a very dynamic process. But it's true that there are some patients who are likely to have more progressive liver disease, and we'll discuss who those might be. In terms of histology and the fibrosis that we see in steatohepatitis is different than what we would see in hepatitis B or C. It's chicken wire fibrosis, mainly in zone 3, so around the central vein. That's where it starts and goes towards the portal areas. The 3 cardinal features in steatohepatitis are steatosis, lobular inflammation with ballooning, and with or without perisinusoidal or zone 3 fibrosis. It's the 3rd leading indication for liver transplantation in the US. In California, 2nd leading indication, and is likely to be the leading indication in just about a decade. So we think about 20 million Americans may have NASH, and when I'm examining or seeing patients in my clinic, about 50% have fibrotic disease. And about 15 to 20% of patients with NASH will go on to develop cirrhosis. How long does it take? It takes about 30 years for someone who has stage 0 fibrosis to develop cirrhosis due to steatohepatitis. But about 20% of those patients can have rapid progression to cirrhosis or advanced fibrosis just within 5 to 10 years. And these are called the fast progressors, and this is the greatest unmet need in the field currently to identify those who have rapid progression. Once you develop cirrhosis, what is the risk for hepatocellular carcinoma? The risk is about 2 to 3% per year, and this risk is less than what we would typically see with, say, hepatitis C or hepatitis B, patients who are infected with the virus and still have it. Once you develop cirrhosis, the risk of liver-related mortality really goes up, and this risk is as high as 30 to 40% over 5 years in these patients. Overall, in patients with NASH, the number one cause of mortality is cardiovascular disease, number two is cancer, and liver disease is third leading cause of mortality. It jumps from 12th leading cause in general population to third leading cause of mortality. Now, there are patients with NASH who may not have cirrhosis, they may bypass and could develop hepatocellular carcinoma early on. But we don't know how to identify those patients, so that is also another area of research. But currently, we don't recommend routine HCC surveillance in patients with NASH. There's a new document that will be coming out from American Gastroenterology Association looking at best practice evidence or advice among patients with NAFLD as to what to do, who should be screened, and how. That should be coming out later this year. Now, this is a simple task that we started. Currently, if you look at the NAFLD practice guidance by AASLD, there is no screening recommendation. So we shouldn't be screening for NAFLD, which is, I think, true, but we should be screening for someone who would be at increased risk for stage 3 and stage 4 fibrosis. So this study actually came out from one of the discussions that we had in the San Diego GI Society community, and I started this study a few years ago. We said in primary care, type 2 diabetics coming in, we brought them to research clinic, and did MRI on them and MR elastography. What we found was 65% of those had NAFLD and about 7% had advanced fibrosis. We even found one patient with hepatocellular carcinoma. Now that's just 100 patients. So now we're doing a validation study in 500 type 2 diabetics, again in primary care. They're coming in. At that time, we had done advanced imaging only. Now we're doing MRI, MRE, also doing FibroScan. We're also doing ELF and FIB4. So you have all these modalities to screen those patients who may have advanced fibrosis. We're already up to about 320 patients, and what we are finding is that the prevalence is about 10 to 15% in a 50-year-old diabetic. So the idea would be that in future, when you're seeing a 50-year-old diabetic for a colonoscopy, you might actually do some sort of testing to see if they have advanced fibrosis also, because 1 in 10 may have advanced fibrosis. Another clinical question that came again from our clinic is, we see these patients with NASH cirrhosis, and they generally come with a family member. They're sitting right next to them. It could be a brother, sister, or an offspring. So what is their risk? Should we be screening them? And to answer that question, we didn't have any data. Again, if you look at the NAFLD practice guidance, it says no familial screening should be performed. So we brought all patients that are diagnosed with NAFLD, and I'm actually getting several referrals from LA. We have a patient coming from Philadelphia. We are flying the entire family. And what we are finding is that those with a first-degree relative with advanced fibrosis or NAFLD cirrhosis, they have 1 in 5 times risk of having advanced fibrosis based upon MR elastography. Now, you couldn't have done these tests earlier because you can't biopsy normal people because you don't know if they have disease or not. So we were designing a protocol where we could do things non-invasively with advanced MRI. And that's what we did. And the red bar is showing you that the risk is about 18% among first-degree relatives of those with NAFLD cirrhosis. So again, I think this was published 2 years ago in JCI, and we're developing this bigger cohort with 100 families. Once that's validated, hopefully we'll change the NAFLD practice guidance where we start screening these family members. Now, how are we able to do that? And I think many of these changes that have happened both in epidemiologic studies but also in treatment response assessment in early NASH trial is based upon some of the MR imaging, liver fat and liver fibrosis quantification that we have been working in Southern California and at UCSD. So these are two modalities to quantify fat in the liver. CMRI PDFF, or proton density fat fraction, and to the right is the magnitude-based MRI proton density fat fraction. One developed at University of California, San Diego, the other one at University of Wisconsin. This is a patient of mine with NAFLD. Both the tests are giving you 29% fat in the liver, so both work very well. You can use either of them. Now, these tests are available on a routinely available MR scanner, 1.5 Tesla or 3 Tesla, and gives you the same results. So it has improved upon previous methods to quantify fat, where previously, if there was inflammation or iron overload, it would give you a false reading about the liver fat content. And proton density fat fraction has eliminated that bias, so now we are able to quantify fat really appropriately with very good confidence and high reproducibility and precision. What about fibrosis? As we all know, that fibrosis is the key determinant of mortality, as shown in this study, where we pooled data from 5 cohort studies with stage-specific risk of mortality. And what we are showing here is that the risk starts increasing, especially in advanced fibrosis, stage 3 and stage 4, and the risk is exponential. And that's why we're screening for advanced fibrosis in all those studies, because we want to eliminate this risk. This also tells us why, for the FDA registrational trial, we need to have stage 2 fibrosis or higher in a patient with steatohepatitis, because the risk of liver-related mortality is higher. And so with this justification, all attempts that we are trying to do is not to screen for NAFLD, but to screen for advanced fibrosis, because stage 3 and stage 4 is what we want to detect, and I think we have tools now to detect those non-invasively. And how we could do that, this study with MR elastography, we started about 7 years ago, published in 2014. We had 117 patients with biopsy-proven NAFLD with contemporaneous MR elastography. And what we found was the diagnostic accuracy for MR elastography was about 92% to know if a patient had advanced fibrosis or not. And so with such an accurate test, that's how we were able to apply that now in the families with NAFLD cirrhosis and also in type 2 diabetics, because we didn't want to misclassify patients. There were 13 patients who were misclassified in this study. So either the biopsy was wrong or the MRE was wrong. So we brought them back, reassessed their previous biopsy and the previous MRE, and then on 7 of them, we redid the biopsy and MR elastography. And what we found was that biopsy was more likely to be wrong or misclassifying rather than the MR elastography. So the true diagnostic accuracy is even higher than 92% for this test. Now, we've developed a method to quantify fat. We've developed a method to quantify fibrosis. Could we use these methods to assess treatment response in NASH trials? So this really started with Thuyan's trial with colesevelam that was published in 2012, where we looked at liver fat in each segment of the liver. As you know, there are 9 segments in the liver, and what we found was that the liver fat was heterogeneous between one segment and another, and there could be big differences, such as 5 to 10% differences segment to segment. So we said you had to look at the same spot before and after treatment. That's what we call co-localization of regions of interest. So now we create a fat map of the liver, and we usually have 9 regions of interest, one in each segment, and look at the same spot before and after, such as this. So to the left, I'm showing you a fat map of the liver, week 0, and then at week 24, looking at online segments. And this really helps with looking precisely if a patient's liver fat is going down or up. Because you can see that if you look at liver fat here is about 23%, and here's 28%, and you want to look at the same spot before and after. So if you looked here in the left lobe, in the morning it's 23%, and you looked at the right lobe in the evening, it'll be 28%. You might think there's a 5% difference. That's the reason for co-localization. Look at the same spot each time when you're assessing longitudinally. Same idea we translated into both 2D and 3D MRE, shown to the left here, week 0 and week 24. Why is MR elastography more accurate than FibroScan? The reason for that is you're getting a bigger sample of the liver out. In FibroScan, you're getting about this much of the liver assessed. Nothing wrong with it. I think it's a very good test. But with MR elastography, you're getting a much bigger sample of the liver. And with 3D, as shown in the lower 2, you can get the entire volume of the liver out, so the diagnostic accuracy is even higher. It's like 98%. Now, what that has done is it has improved our precision and accuracy in phase 2A trials and improved responsiveness. So we are able to do shorter trials now, as opposed to, say, with Pivens, it was a 2-year trial, and then Flint was 1.5 years. Now, many of our early phase trials are 6 months, sometimes even 12 weeks, and I'll show you some of those data. We are using now MRI PDFF in about 25 trials, many designed at UCSD, and then MR elastography in about 10 different trials. I'll show some of them to you today. Now, what about the patient in the clinic that you're going to see today? What sort of advice that you can give them and how we can treat them today? And then we'll discuss future therapies as well. Well, weight loss is important, and however you can achieve it, although it's difficult to achieve, there might be certain benefits. And if your patient achieves certain amount of weight loss, you don't have to repeat a biopsy because you can actually give them some advice based upon what they may have achieved. So even small degrees of weight loss can actually start trending the patients in the right direction. So even if somebody lost 3 to 5% of body weight, it's good for them because they're preventing their progression of disease. But about 5 to 7% weight loss is when you start seeing improvement in ballooning or inflammation. About 7% weight loss, you could start seeing resolution. And then about 10% weight loss if you have. So a 100 kilogram patient goes down to 90 kg, you may start seeing improvement in fibrosis as well. However, it's not very easy to achieve this, and only less than 10% of patients that we would have would achieve 10% weight loss in a year. But I think it's still beneficial because many patients do benefit from that. And as long as your patient is not gaining weight, I think you're still preventing their progression rate in terms of disease progression over a long time. I'm going to show you some data on how to use vitamin E and how that data is derived. This is based upon Pivens trial, published by Arun Salnial on behalf of the NASH CRN, where patients, about 247 were randomized to vitamin E 800 units daily, or pioglitazone 30 milligram daily, or placebo. Vitamin E in green, placebo in red, and pioglitazone in black bars. And so vitamin E was better than placebo, but so was pioglitazone in improving liver histology over 96 weeks. And these are some of the key caveats. So vitamin E more than 400 units is associated with increased risk of cardiovascular risk. And this risk is mainly hemorrhagic stroke. So at say 1600 units of vitamin E, it increases risk for bleeding. But it's preventive for ischemic stroke. So the patient that you may not want to use vitamin E would be somebody with uncontrolled hypertension. Those would be the patient at high risk for hemorrhagic stroke. There's also a slight increase of prostate cancer risk in men. And so, being cognizant of that fact would be important as well, as you discuss with your patient. Pioglitazone, there's a small risk of early onset edema or weight gain, and then increased risk of osteoporosis, and a small risk of bladder cancer. So these could be used selectively in some of the patients. I would use vitamin E in patients who have NASH with early fibrosis, especially in women. And this works very well, especially if they have controlled high blood pressure. What about emerging therapies in steatohepatitis? What I've done here is I've grouped therapies in various columns. And under the columns, I've put in some important mechanistic pathways that some of these drugs may be affecting. And under that, in a row, I've put in the histologic variables that they may be solving or may be acting on. And based upon this is how I'm deciding which therapy I would took and how I'm going to decide on the outcome of interest. And so you'll say, you design this trial, and the outcome here is NASH resolution, and then you design another trial, and here the outcome is prevention of progression of cirrhosis and its outcome, and then one-stage regression of fibrosis. And how are you choosing those outcomes? And it really depends on the mechanism of action of the drug, the mechanistic pathways that they may be altering, and then the improvement in the specific histologic features that I foresee early on. And based upon that, I'll choose the primary endpoint of those trials. With that, I'll move on to some of the key therapies that are either in phase 2 or in phase 3. This is a Flint trial that Brent and I designed, again for the NASH CRN, where we use obeticholic acid versus placebo for treatment of NASH. 282 patients. Again, this was a 72-week trial. And what we found was that 46% of patients on obeticholic acid, this is 25 milligram dose, higher dose than what you use in PBC, versus 21% of placebo had improvement in liver histology with no worsening of fibrosis. And this trial also showed that you could improve fibrosis with the obeticholic acid. There were severe pruritus associated with OCA, which is the FXR ligand. That was about 3%. And it led to increase in LDL and total cholesterol and a mild decrease in HDL cholesterol that is being evaluated in terms of its impact on CVD health. This went on to the Regenerate trial, and this is a phase 3 trial where patients were randomized to obeticholic acid 25 milligram, OCA 10 milligram, or placebo. Trial is still ongoing, but the primary for registrational subpart H analysis, about 1,400 patients were to be enrolled in this trial. What they're finding is, this is the key press release data also presented at EASL, that 23% of patients had one-stage improvement in fibrosis with no worsening of NASH with the 25 milligram. There's a good dose response here, and placebo response is about 11.9%. So you're getting about 11 to 12% treatment effect delta on one-stage improvement in fibrosis. Typically, what you'll see in phase 2B trials, you have a better treatment effect delta, and as you go toward phase 3 trial, the treatment effect delta gets smaller. And this is going to be the case in all of our phase 3 trials. Elafibranor is a PPAR alpha delta agonist. This is now currently in phase 3 trials. We expect data sometime by 2021 or end of 2020. Patients were randomized in this trial, 270 patients with biopsy-proven NASH to elafibranor 120 or 80 or placebo, and the endpoint here was resolution of NASH. The primary endpoint was not met if you looked at all the subgroups, but when you looked at those patients who actually had NASH that we currently treat in a phase 2B trial, then those patients actually responded well with a treatment effect delta of about 10% for NASH resolution. NASH resolution is a tough endpoint because for it to be achieved now, you have to bring down the ballooning to 0 and lobular inflammation to either 0 or 1. Now, you might have heard about GLP-1s, and you might have used them also in some of the patients who have type 2 diabetes. These drugs have been used for treatment of obesity as well. They lead to reduction in body weight, and the primary mechanism is related to improved inflammatory status related to weight loss. How do they work? They basically work centrally in terms of they give a signal to your hypothalamus to eat less, and so you have an early satiety. And patients also early on may have some nausea. As you know, some of the GLP-1, especially the earlier ones, were associated with acute pancreatitis as well. The later generations are much safer. This is a small study done in the UK showing that liraglutide, a GLP-1 analog, is associated with improvement in resolution of NASH if treated over 1 year relative to placebo. Small sample size though. There's a trial with phase 2b trial with semaglutide that is underway currently. We'll have data next year in patients with NASH stage 2 and stage 3 fibrosis. We recently started a cirrhosis trial in patients with NASH cirrhosis with semaglutide to be treated over 1 year for treatment of NASH-related cirrhosis, and that would also be out by 2021. Cenicriviroc is a CCR2, CCR5 blocker, initially hypothesized to be an anti-inflammatory drug. They had 1 year data with CVC 150 milligram relative to placebo. What they found was a 10% treatment effect delta, so 20% of patients on CVC had improvement in one stage of fibrosis relative to about 10% of placebo. This is also in phase 3 trial. We expect data in about 3 years. This is looking at ASK1 inhibitor. This was the phase 2b trial. This was a 6-month trial. This is the data that led to the selonsertib phase 3 program that recently read out. Looking at 18 milligram dose, showing you 43% improvement in one stage of fibrosis relative to 30% on 6 milligram, and then simtuzumab, which, as you know, previously shown to not work. It's an anti-LOXL2 antibody for treatment of fibrosis. This was read, but recently we had a press release from Gilead that selonsertib was not better than placebo in improving stage 3 fibrosis or stage 4 fibrosis. So that trial was stopped early. Now, later this year, we're looking forward to the ATLAS trial result, which is a big combination 3 international trial that includes a ACC inhibitor, I'll show you some data, an FXR inhibitor combination, and also alone in about 400 patients. This is the ACC inhibitor phase 2a trial, where we designed the trial with a 20 milligram dose versus 5 milligram dose versus placebo. What does the ACC do? Well, it basically blocks fatty acid synthesis. And the hypothesis is that it will reduce liver fat, and we could use MRI-PDFF in our 12-week trial. And this is what we did. And what we are showing here in the red bars is about 29% reduction in MRI-PDFF relative to baseline in the 20 milligram dose. And about 50% or so patients have 30% or more relative reduction in MRI-PDFF in this trial. And that's why it's now in a phase 2b biopsy-based trial. This is looking at FGF21. There are 5 different companies that have a FGF21 program now. This is looking at the BMS compound. In animal models, FGF21 leads to weight loss. How it is doing it is, but independent of weight loss, it can improve liver fat. And this is usually thought to be an effect related to PPAR alpha activation in the liver and PPAR gamma activation in the peripheral adipocyte. Also leads to release of adiponectin, which is beneficial, as you know, and can lead to a reduction in both liver fat and may potentially lead to improvement in fibrosis. This is what's shown here, that you could start seeing improvement in MR elastography with FGF21 just over 16 weeks. And so one example of this trial, and to the left I'm showing you ProC3, which is a fibrosis marker, also showing you some data on hyaluronic acid, another fibrosis marker, and a hallmark of FGF21 class, increase in HDL cholesterol. This trial is now, with this particular agent, in a phase 2b trial in patients with NASH cirrhosis, and also with NASH stage 3 fibrosis. This is another compound which is looking at thyroid hormone beta receptor agonism. So thyroid hormone receptors are in the liver. It's a nuclear hormone receptor, but also could be in the hypothalamus or the muscle. This particular drug is preferential towards the liver, and so it can actually burn liver fat without affecting any other parts of the body. Showing you pretty decent reduction in MRI-PDFF, as high as 90 to 100% with just 5 milligram orally daily. This is now going to a phase 2b trial in patients with biopsy-proven NASH and fibrosis. As Nora just showed you data on the siRNA-based modalities, this is a San Diego-based company, Ionis, that specializes in antisense molecules. The idea is that you deliver an antisense, and the beauty for antisense is that they can be specifically tailored for liver. So you could design it that it'll only work in the liver and leave the rest of the body. So if you know a gene that's active, leading to a disease or phenotype, you can actually block in the liver. So this is going to be new treatments that will be coming out for alpha-1 antitrypsin and also genetic modulation in the liver. In this particular case, what INS developed was a DGAT2. It's a final enzyme before triglyceride synthesis. So it blocks fatty acid synthesis, the final step. And by DGAT2 inhibition, what I'm showing you, there was a significant reduction in liver fat, about 30% in these patients just over 12 weeks. So this is also now moving towards a biopsy-based trial. These are the agents that are currently in phase 3 clinical development. Sanifcriviroc we discussed, elafibranor we discussed, obeticholic acid, selonsertib, data just released as press release, and then the Madrigal thyroid hormone beta agonist. This is in phase 3 trial now. The endpoint for the Madrigal compound is NASH resolution without worsening of fibrosis. And as you know, thyroid hormone beta receptor agonists would also lead to reduction in liver fat significantly. Major unmet need is in patients with cirrhosis due to NAFLD, and there are many factors. We think we would have a treatment for NASH-related fibrosis pretty soon, but for cirrhosis, we will have to do things differently. Because in subset of patients, it may be irreversible. And so we don't want to tackle those patients early on where the therapies might be working, but we may show that the therapies have no effect just because we included patients who shouldn't have been included in those trials. Liver biopsy, I think, is impractical for showing improvement, and I think the future is going to be on non-invasive ways of showing that liver disease is improving rather than using liver histology. Again, HVPG is not going to be the way to go there because I think it's unreliable, and 2 trials have already failed using that particular endpoint. So I think the push is towards more quantitative biomarkers, and I think this is where MR-based modalities will be more frequently used. In conclusion, NASH can lead to cirrhosis and hepatocellular carcinoma. Fibrosis is the most important prognostic determinant of outcomes in NAFLD. Lifestyle interventions can improve steatohepatitis. Vitamin E at 800 units can be useful for treatment of your patients today. There are several exciting molecules in clinical development. We have several studies in collaboration with many of you where we are trying to screen for advanced fibrosis, such as patients who have type 2 diabetes 50 and older, or anyone with suspected NASH cirrhosis and their first-degree relatives. And we're also planning on starting a major study similar to the Dallas Heart Study. That'll be called the San Diego Liver Study, where we will monitor about 2,000 patients longitudinally with advanced MRI in near future. So with that, thank you very much. Appreciate it.